topic. Dr. Dronamraju obtained her medical degree at the Tufts University School of Medicine, and subsequently did the rest of her training at Mount Sinai, which is also my alma mater. So I am a little bit jealous that she got to do her hepatology fellowship there as well, under the direction of Dr. Scott Friedman, again, one of the legends in the world of hepatology. Her interests include improving quality of life in patients with chronic liver disease. With that, please help me welcome Dr. Dronamraju. Thank you.
How do I, is this what I use to move the slides? Hi, everyone. Thank you so much for having me here today. My name is Deepti Dronamraju. I'm a transplant hepatologist at Stanford, and my practice is predominantly in the East Bay out of Pleasanton. Just get to my slides. Okay. So I've been tasked to talk to you today about off the beaten path viral hepatitis. As you know, these are the things that we always tend to forget. So it's always nice to have a refresher on the management and treatment of these conditions. So the classic hepatotropic viruses, as you all will recall, are hepatitis A, B, C, D, and E. These may cause anywhere between a self-limited infection and otherwise progress to a more chronic infection. But there's many other viruses out there that can cause systemic illness and also have liver manifestations as well. And these pose a greater burden to our patients who are immunocompromised, especially in the post-transplant setting. The presentation of these viruses can also vary anywhere between asymptomatic rise in liver enzymes to a more fulminant liver failure type picture. So the viruses I'm going to be touching base on today include hepatitis D, hepatitis E, the human herpes viruses, herpes simplex, varicella, Epstein-Barr, CMV, and then because of the times that we live in, I will also touch on SARS-CoV-2. So hepatitis D is one of the causative agents of one of the more severe types of chronic viral hepatitis that we see. As you will all remember, it's a defective RNA virus that infects patients who have a chronic Hep B infection. It can either present as a co-infection at the time of acute Hep B infection or as a superinfection in those patients who are already chronically infected with hepatitis B. It affects about 5% of the world's population who has hepatitis B, and that in and of itself is not an insignificant number. It's upwards of 15 million patients, but it's likely underreported, and the true number is likely much greater than that. So that's important to remember. Hepatitis D has 8 different genotypes, and though we can't routinely test for the genotypes, it's important to know that they exist because they can affect the clinical outcomes. Genotype 1, for example, which is seen in the United States and South America and parts of Asia, is associated with a more rapid progression to cirrhosis and has an increased risk of HCC, whereas genotype 3, which is more prevalent in South America, can present with a severe hepatitis and high rates of acute liver failure and death. Interestingly, there's some suggestions that genotype 3 may be more responsive to therapy. In terms of the serologic course for hepatitis D, as I had mentioned earlier, it can have either a co-infection when it presents as an acute infection alongside hepatitis B. And in these patients, it's generally a self-limiting infection that can cause jaundice and an icteric hepatitis. The markers of acute infection for both hepatitis B as well as hepatitis D will be present. And the presence of the core IgM for hepatitis B can really distinguish this condition from a superinfection. Superinfection is seen in those patients who are chronically infected with hepatitis B but are otherwise stable, who then develop an acute hepatitis. This can often mimic an acute flare of their hepatitis B, but the key here is that when you check the Hep B PCR, it will often be suppressed because of the hepatitis D viremia, and they will have low Hep B levels and high Hep D levels. And in these patients, the Hep D viremia can persist into a more chronic state and will have sort of waxing and waning titers. There are several diagnostic tests available for hepatitis D. I'd like to just focus on the ones that are more likely to be available in clinical practice for you to order. Hepatitis D IgG antibody and hepatitis D RNA PCR, either qualitative or quantitative. The Hep D antigen is only transiently elevated, so it's not used typically. And we don't usually do the liver biopsies to stain for hepatitis D either because it's not readily available. So the tests that you should look to order are the IgG and the hepatitis D RNA. Treatments are fairly limited, unfortunately, for hepatitis D, and there is a definite need to look for more novel therapies in this virus. The treatment remains interferon-based therapy. Pegylated interferon is preferred, and treatment duration is about 1 year. And even with 1 year of therapy, SVR rates approach only 20 to 30%. And if you were to follow those patients further down the line, 4 or 5 years, that goes down further to only 12%. So they relapse. There's no difference in treatment between pegylated interferon alpha 2A or 2B. But as you all know, the limitations of the therapy itself can prevent us from treating our patients. There's a multitude of side effects in it, and it's contraindicated in patients who have more decompensated liver disease. There is no role for nucleotide analogs in treating hepatitis D. It doesn't affect the replication of Hep D, but there is a role in treating it and controlling Hep B related disease. And certainly in our patients with cirrhosis, you should have them on Hep B therapy. Moving on to hepatitis E. Hepatitis E is actually the most common cause of acute viral hepatitis worldwide. There's 4 genotypes. Genotype 1 and 2 is seen throughout most of the world in Asia and Africa and Central America. Genotype 3 and 4 are more seen in the United States and Europe. 1 and 2 are associated with contaminated water sources. 3 and 4 are associated with consumption of undercooked meat like pork or game meat. In immune competent adults, it is a self-limited illness, lasts about 4 to 6 weeks, presents with a markedly elevated ALT, usually greater than 1,000, and jaundice. There are non-specific symptoms, may have fever, malaise, may have nausea or diarrhea, but its presentation in acute infection can vary very different than those who progress to a more chronic state. So in an acute Hep E infection, you're looking for the IgM antibody and or the hepatitis E RNA. And the thing I'd like to point out here is that hepatitis E RNA is only positive for a short duration of time in the serum. So patients can still have symptomatic presentations, lab abnormalities, and no longer have Hep E RNA in the serum. They will continue to shed it in the stool for longer periods of time. But if you check a Hep E RNA and it's negative, it does not exclude an acute Hep E infection. The Hep E IgM antibody will be positive for several months. And so that should be the tool that you use to diagnose an acute Hep E infection. In those patients who progress to a chronic infection, which is an infection that lasts 6 months or longer after the initial infection, these patients are usually immunocompromised patients, and it's usually exclusively seen in genotype 3 infections. They don't have as robust of a ALT response. They may only have modest elevations in their liver enzymes. So the diagnosis here may be a little bit more difficult to make. Acute infection in immune competent hosts does not require any treatment. In patients who are have a secondary chronic liver disease who then have superimposed hepatitis E, there have been some data to suggest that you might consider treating those patients with ribavirin monotherapy. For those patients who are chronically infected with hepatitis E, the The goals of therapy are really twofold. One is to reduce immunosuppression, and by reducing immunosuppression, a third of patients will clear the virus with that alone. And for those patients who don't clear the virus after reducing immunosuppression, you would consider ribavirin monotherapy for 3 months. And for those patients that are actually showing good response or partial response to the ribavirin but haven't quite cleared the virus yet, you may extend the therapy beyond to up to a year. Median dose of ribavirin that was shown to be highly efficacious was 8 mg per kg a day, or 600 milligrams a day on average. Moving on to human herpes virus, there's 8 known viruses that are known to cause disease in humans. These are the viruses that are characterized by an initial self-limiting infection with a subsequent period of latency, followed by reactivation. Injury here is due to direct cytopathic effect of the virus and a pathologic immune response. So herpes simplex virus, the primary infection often is asymptomatic, or it may present with a vesicular eruption. In immune competent adults who present with an acute HSV2 infection, up to 14% may have some mild asymptomatic rise in their liver enzymes. HSV hepatitis is a much more severe infection, and its morbidity and mortality is really in patients like neonates, where it's one of the torch infections, and pregnant women, especially late in their pregnancies, and immunocompromised persons. And these population groups, HSV has a mortality as high as 80%. The clinical presentation of HSV is really leukopenia, fever, and the marked elevations in the ALT. You cannot depend on the mucocutaneous manifestations to make the diagnosis, as those are only positive in 50%. So if you're suspecting the diagnosis while you're sending off the diagnostic tests, you should go ahead and start therapy given that high mortality. The serologies and PCR should be sent. Liver biopsy is considered to be the gold standard, but it's often not feasible to do. Risk factors for progression of the disease to death and/or transplant include male gender, age greater than 40, ALT greater than 5,000, a platelet count less than 75, and lack of antiviral therapy, as would be expected. On histology, you will see a grossly mottled appearance, moth-eaten appearance of the liver with focal extensive coagulative necrosis. The key histologic finding is the Cowdrey body, which is an eosinophilic nuclear inclusion that's seen in the hepatocytes at the periphery of the necrotic tissue. You also may see multinucleated hepatocytes with ground glass appearance to them, suggestive of the viral inclusions. The management of HSV is high dose acyclovir, 10 mg per kg every 8 hours. You should empirically treat the patient because of that high mortality rate while you're working on confirming the diagnosis. Acyclovir is safe in pregnancy. Duration, it may need to be a prolonged course of antiviral therapy because there is a risk of relapsing infection. Those with fulminant liver failure should present to liver transplant if they are healthy enough to make it to liver transplant. But the outcomes here are not great. 5-year survival for adults was as low as 38% in one study, and slightly better for pediatric patients at 69%. Varicella zoster virus is a very rare cause of hepatitis. It can also lead to asymptomatic rise in liver enzymes, especially in children, where it's seen in a small percentage, but not a common cause of hepatitis. But when it does present, it can also present very much similar to HSV and can have high rates of mortality. So it is also treated with high dose IV acyclovir. Visceral involvement, again, can precede any cutaneous manifestations, so you cannot count on finding the characteristic skin lesions to make the diagnosis. Here, you would send off a VZV PCR. Epstein-Barr virus, as you all know, is the causative agent for mononucleosis. It can present for mono as pharyngitis, fever, lymphadenopathy, and liver involvement in EBV is very common, although usually it's all subclinical. Patients may have a rise in their liver enzymes that will improve even before their clinical symptoms improve. And the rise in the liver enzymes is usually less than 5-fold the upper limit of normal. Jaundice in EBV is rare, but it's important to know about because it's also a rare cause of fulminant liver failure, even in the immune competent adult. And for post-transplant patients, it is associated with post-transplant lymphoproliferative disorder. Again, EBV reported hepatitis is a relatively rare condition, less than 1%. 12% of the patients who present will have some symptoms of mono preceding it, but 88% will have the evidence of splenomegaly as well as the lymphocytosis. The diagnosis is made by checking the IgM antibody for EBV specific immunoglobulin. Liver biopsy is rarely needed. And if you did do a liver biopsy, you would really see portal and sinusoidal mononuclear cell infiltration without disruption of the hepatic architecture. You don't see giant cells or any of those inclusions. Treatment is supportive care. Acyclovir may reduce shedding, but it doesn't affect the clinical outcome. So we just treat it supportively. And again, as I mentioned, in patients who are post-transplant, you do want to keep in their EBV status in mind because it may be a cause of lymphoproliferative disease in the immunocompromised patient. Cytomegalovirus is another torch infection. Its typical presentation is a mono-like infection. 88% of patients will have evidence of liver enzyme abnormalities. Major populations where it can cause severe disease are the babies, congenital CMV infection, as well as organ transplant recipients who can present with a more aggressive form of hepatitis. It can often be difficult to diagnose as either a CMV infection or as rejection. So here it's important to know about it and test for it. And oftentimes you would do that with both serologic and nucleic acid studies, as well as a liver biopsy in transplant patients. So primary CMV infection will have IgM antibodies being positive. And in those patients where you're suspecting reactivation, you would actually be looking for CMV in the blood. Treatment is IV ganciclovir that should be continued until CMV is undetectable. Alternative agents for those who don't respond include foscarnet and cidofovir. Here, the classic finding for CMV is the large nuclear inclusions, also known as owl eye inclusions within the hepatocytes. You will see multinucleated giant cells, and you can also see cholestasis. And the last topic I'd like to touch on, just because we're seeing so much of it, is SARS-CoV-2. SARS-CoV-2 is an RNA virus. It binds to cells using the ACE2 enzyme, which is found on both liver and biliary epithelial cells. And so it does have liver manifestations as well, although these are usually transient and seem to be much less severe than the respiratory manifestations. But in terms of how often they're seen, they're fairly common to see liver chemistry abnormalities in patients with COVID-19, and up to half the patients who present to the hospital with COVID. Again, less than two times the upper limit of normal, and most oftenly seen in patients with severe disease. There's no specific treatment that's required here, and it's usually just treated with supportive care. A study out of MGH looked at 60 patients and followed them through their COVID hospitalization. And in particular, AST elevation was noted to be more significant than the ALT elevation. And this AST elevation did not parallel the CK elevation. So it's a primary liver injury, not so much a muscle injury. And that's been shown in other studies as well, that it seems to be a more predominant AST elevation. Histologic findings of COVID-19 infection. is typically microvesicular steatosis, and the study that looked at patients at autopsy, 75% of patients had evidence of microvesicular steatosis. There was also mild lobular and portal activity, but it's not clear yet whether this is due to direct cytopathic effect of the virus versus drug-induced liver injury versus some type of immune-mediated manifestation. So the jury's still out as to what the cause of the liver injury is, but these are the findings that people have been seeing. So in summary, the hepatotropic viruses that are important to know about because they cause disease in both the immune competent as well as the immune compromised hosts. The disease burden for non-hepatotropic viruses is really in the immunocompromised hosts, and especially in our post-transplant patients. And it's important to have a high degree of suspicion to make the diagnosis because they have such severe manifestations in some patients. Hepatitis E, for example, I mean, there's increasing data to suggest that maybe many of the cases that are being misdiagnosed as drug-induced liver injury may actually be underlying Hep E. So having that on your differential is important. And I was only able to touch on a few of the viruses, but there are many viral illnesses that cause systemic disease that can range anywhere from asymptomatic elevation to a frank hepatitis and liver failure. Other viruses that do this are influenza, chikungunya, Zika, as well as Ebola virus. So it's important to just know that viruses in general will often have hepatic manifestations of their disease. So with that, I will end and I will take any questions.
Thank you so much for this informative talk. I learned a lot. A question from our virtual audience. Out of the 15 million of estimated Delta infections worldwide, do we have an estimate of how many people have active viremia that may require treatment? And the second part of the question, if the patient had cleared the Delta infection, is there any monitoring that is necessary?
I am not aware that we know how many have active viremia. I'm not sure that that data is available. I know it's difficult to even order the test if you're in clinic trying to get the right test done. I don't think that if you clear the infection that you would need to monitor them unless you're seeing some new rise in the liver enzymes that would cause you to suspect that something else may be going on.
Thank you for that talk, Dr. Dronamraju. Just a quick question. I was surprised, and I don't think I knew about that markedly low survival after transplant in HSV patients. Do you know why that is? Is it because they infect their graft or they're so sick going in? Or I was curious about that.
Yeah, I assumed it was that they were so sick going into the transplant, but I'm not sure if that it is involved with graft infection afterwards as well.
Thanks, Deepti. That was great. I had a question, just thinking more about the COVID and you showing the histology there. Are you guys using COVID positive donors for transplant at this time? Are you thinking about it?
I don't think we are. No.
We've done 2 now. And it just raises the question, what's causing the hepatitis there? Is there virus in the liver? You know, we have criteria for selecting these donors. It's a very new protocol, a couple case reports out there for others having done it. It's just something I think, unfortunately, we're stuck with now and may need to be thinking more and more about it. But all right, thank you.
Thanks.